patient comes in, I have rhinitis, do I have cold, I have allergy, I have a sinus problem. What is this? So let's give you a little bit of definition first, okay? So,
here,
sorry. Thanks.
Works easier.
So, rhinosinusitis, means the word sinus, is a symptomatic inflammation of your paranasal sinus and your nasal cavity. Okay? Now, inside your nose, a lining just like your skin. However, it's much thinner. Okay? And it has these cavities around your face. It's actually, inside your face is hollow. There are two sets on the face here, called the maxillary sinus. On top, called the frontal. Between your eyes, called the ethmoid. And all the way back, it's called the sphenoid sinus. Okay? Now, before we even go on this, what is the function of your nose? Why do we need our nose? There are a couple functions. One, of course, breathing. Second, is the nose is there to humidify the air. Right? Warm up the air. Every guy trying to breathe through your mouth, you get so dry, it's cold in the wintertime, it's cold. That's what your nose does, right? So the nose nasal lining is full of mucus cells, and also underlying is full of venous. So there with a lot of blood flow in there. So it can really heat up the air and warm up the air. Sinusitis is basically all the lining of the mucosa gets inflamed. Now, makes you say, hey, isn't that just a cold? Yes, technically it is. It's a cold, basically, that extended into your sinuses, into these little pockets of cavities. And what happens when you have inflammation? What is inflammation? What is the difference between inflammation and an infection? I think that's one of the fundamental things most patients don't understand. Inflammation is a response, your body responds to an event. Could be from infection, could be from autoimmune disease, could be from trauma, anything. A lot of things can cause inflammation. Okay, it could be allergies. When you have allergy, you have inflammation, right? So all these things can cause sinusitis, but most of the two types of sinusitis that we're concerned about are virus and bacteria. So before I go up, we talked about the inside the nose. So inside the nose, we have the two sinuses I showed you before. This is a lateral picture. You have these things called the turbinates. They're just outpouching from the lateral wall into the middle of the nose. And these turbinates are where, if you look at the nose, you pull your nose up, you see they're on the side, they look like two round stuff. I don't know if anybody looking in the mirror and looking up your nose. I'll show you a picture later. You can see where the turbinates are. These are the things that actually warm up. This is really what warm up your air and filters the air and also humidify the air. Now, anybody ever had this experience when you lie down in the middle of the night, go back to sleep, you feel like your nose is more congested in the daytime? I think probably 90% of people do, right? And also sometimes you feel one side of the nose gets clogged. After a little bit, the other side gets clogged. Or if you sleep on this side gets clogged. You go on this side, the other side gets clogged, right? It's very common. That's the culprit. The turbinates, okay? Remember I said the nose is full of blood vessels, so inside the turbinate there's all these soft tissues, it engorges the veins, and there's a lot of blood in there. So what happens when you're standing? Where does the blood flow? Downwards, right? So what happens when you lie down? Your heart and your nose at the same level, right? So the blood doesn't return down as much. Now, of course, the people who has allergies, people who has sinusitis or an infection, it gets more swollen than you're breathing. You can't breathe as well. And there's something called also nasal cycle. Every 90 minutes, the two turbinates alters. One side gets a little bit bigger than the other side. Also, if you turn this side, blood flow down to this side, so it's a little harder to breathe on this side. If you turn on this side, blood goes down that side, so this side gets a little harder to breathe. Okay, so at least this is something we can understand. Now, also inside the sinus, it's also the same type, exact same type of lining as inside the nasal cavity. And especially on these sinuses, there are little cilias, the little hairs that beats. Why does it beat? Because inside the sinus, it produces a mucus. Basically, the mucus is there really to lubricate, to filter, to trap dust, to help you, warm up the air. So it constantly produces mucus, and it transports it through these little osteums, okay, and then back into the nose. Now, what happens when you have an allergy or anytime you have any infection? The mucosa lining gets very swollen and it can block these output, the drainage pathway. And that's when you have mucus buildup inside the sinus. Okay? Yes, go ahead.
Okay, what can you commonly do for that?
For the sinus. Well, we'll get to that, okay? So there's a few definitions. I want you guys to first understand what is sinusitis and what is a cold before we go on to what you do, okay? So when that buildup and bacteria gets in there, that's when you have a sinusitis. Okay, so this is probably the most question. What is a sinusitis? Why is a cold allergy? How is it different? So, sinusitis can be, we'll separate to two things. One's a viral sinusitis and also a bacterial sinusitis, which is caused by virus and caused by bacteria. Most of the sinusitis, just like a cold, it's mostly caused by bacteria. Okay? Now, usually, as I said, it's almost the same thing, except it goes into the sinus. So when you have, but it's more severe. When you have a cold, usually it's a virus infection. It heals within about a week. It'll get better. Whereas the sinusitis has more symptoms, it doesn't get better as fast. Most people have symptoms of pressure around the face. They have runny nose. The three main things. Back then, the actual definition of sinusitis, you have to have 2 major symptoms and 1 of the 5 minor symptoms. Now the definition is a little less. You have to have 3 cardinal signs. One is nasal obstruction, facial pressure or headache, okay, and nasal discharge. Those are the 3 main things to call you a sinusitis. Again, sinusitis is a clinical diagnosis. A CT scan, radiograph, does not diagnose sinusitis. It's really by your symptoms, okay? Some people, oh, I got headache all the time. But he never had, most of my patients come in for, I guess a lot of patients send in for headaches. You never have runny nose, never have nose obstruction. You don't have sinusitis. You probably could have other things. You could have migraine, you could have trigeminal neuralgia, there's other things that can cause that. Many of them will work at that level. But most people, if you don't have those 3, you might not have sinusitis, okay? So again, you look at this chart here. See, you have to have nasal discharge, but it's not really that much different between a cold. You can have thick and whitish, and you have a cloudy color. Cloudy means it could be green, it could be yellow. That doesn't tell you if it's a bacteria or it's a virus. And it's not the bacteria and the virus that's yellow or green. It's really the white cell. It's your own body immune response. The dead white cell, that's what gives the yellow or green appearance. Okay? Some people might have fever, but you have to have most of the time have sinus pressure. But cold, you can also have it. So sometimes it's actually very difficult to distinguish between, do I really have a cold or sinus? But the treatment is the same. Okay, but we'll talk about that in a little bit. Well, this is so before even talking more about sinusitis, this is, I think, something most people will have. Most of my patients comes in, oh, doc, I have sinusitis. After I look at them, asking history, they don't have sinusitis. Most of the people have one of these 3. Allergic rhinitis, vasomotor rhinitis, sometimes in the last part is rhinitis medicamentosa. Okay? Again, rhinitis, different from sinusitis, rhinosinusitis. These one of the 3 is also, it's very similar, except your sinus is not involved. Patient, most of what their symptoms are, runny nose, nasal congestion, right? These people season long. For allergic rhinitis, it's basically you're allergic to something, you release a lot of histamine, IgE through the protein pathways, and most people it's seasonal. They'll sneeze, runny nose, but you don't get that yellowish stuff coming out. Usually all clear. And you get very itchy. So it's a symptom that tells you. Okay? And this is pretty easily treated. Most patients, give antihistamine by mouth or even by nasal spray. Okay? You can also do allergy testing. There are multiple ways of doing it. But the key of these are seasonal. The timing of the onset, okay, and also symptom that tells you if you have really allergic rhinitis or if you have something else. And then other way you can do it, you can also go to your doctor, do a skin test, which is pretty easy, it takes about 5-10 minutes, and you can find out if you have really an allergy or not. Vasomotor rhinitis. Now, this is actually a tough topic here. It's actually not very well understood. These are the people who has eating food, they have constant runny nose all year round. It's not seasonal. Sometimes a hot food temperature changes, certain odor make their nose runny. They get also low obstruction. And this type of rhinitis actually really doesn't really work very well with all the medication that they have on the market. Because we don't know the exact method, the mechanism of what causes basal odor rhinitis. So treatment is limited. Rhinitis medicamentosa, this is actually an important one. I see these pretty often too. Anybody ever use Afrin? Yeah? It's a great product, isn't it? You spray your nose, so much better. Whereas your doctor gave you Flonase, Nasonex, it doesn't work, right? Let me tell you what Afrin is. The name of Afrin is oxymetazoline, okay? It works almost like cocaine. It doesn't give you the high. But what happens, it constricts all the blood vessels in your nose. So your nose dries out, and you feel great. The problem with that is, you use it after 4 or 5 days, there's something called rebound, okay?
You just said.
Yeah, oh, you said it? Great, smart guy. So rebound, you get worse symptoms, and you get relied upon it. If you don't use it, your nose gets more boggy. It gets more clogged, so you have to keep on using it. Over years, it actually has the same type of effect as cocaine. So when people snort cocaine, what happened to their nose? The blood vessel always gets constricted, the nose gets very poor supply. In their septum, they get a hole in their septum. And they get worse symptoms, they get runny nose, they get this crusting in the nose, they can't breathe. With people who use Afrin all the time, they get the same thing. So Afrin is still, it's over the counter. You don't need a prescription, but the keyword is don't use it more than 3 days. Okay? If you have to use it you need more than 3 days, go to your physician. Okay, this is another one. I just threw it in there. People who are pregnant because the hormonal changes, their nose also gets more boggy, and they can have rhinitis in pregnancy. Unfortunately, treatment is also limited because most of the physicians are also afraid to give nose. There's only 1 or 2 medications that's safe to use. It's Rhinocort. So if anybody who knows women who are getting suffering after they're usually doing the 2nd or 3rd trimester with runny nose, it's not sinusitis. Most of the patient has rhinitis due to their pregnancy. Okay, Rhinocort is the only FDA approved one for the nose. Okay, so this is what we're talking about, acute and chronic sinusitis. This is on the CT imaging where you can see in the maxillary sinus, it's all completely filled up. Even here, you have a lot of fluids. And if we actually put a camera in the nose, you can see pus coming out. Remember the 3 big things I told you about sinusitis? Nasal obstruction, facial pain, and discharge. And usually the discharge is yellow if you look at inside the nose. Okay, we talked about this before. Now, sinusitis can be caused by what? Bacteria and virus, right? What do? Usually, how do we tell if it's bacteria or virus? You really can't. Even if you do a culture, you put a little swab in the nose, you swab that, you can't really tell. So how do we treat it? It's by symptoms, how severe it is, and we usually do watch and wait. Virus infection usually will peak about 3 days, and it'll get better afterwards. Whereas a bacteria usually doesn't get better on their own very fast. It'll linger much, much longer. Okay? Now also this is, again, patient-oriented. For a patient who are a healthy patient with a bacteria sinusitis usually gets better right away. And also don't forget, sinusitis can be divided into acute and chronic. What is the difference between acute and chronic? Acute, less than 4 weeks. Chronic, over 12 weeks. Okay? You have to have the symptoms persistently for 12 weeks to call it chronic sinusitis. Most of the people have acute sinusitis, which is usually about a week or 2. Okay? You know how prevalent is sinusitis? We get 1 out of 8 adults gets sinusitis. 1 out of every 5 antibiotics prescription in this country is for sinusitis. So this is really a big problem with sinusitis. But of course, I think there's a lot of misdiagnosed people who has just rhinitis. I can tell you by my experience, there are a lot of patients comes in, I have sinusitis, doc, gotta give me antibiotics. No, they have allergies, they have rhinitis medicamentosa, or they have rhinitis. So there you the thing, you have to have the 3, okay? A CT scan doesn't tell you have sinusitis.
Why do you make a difference between acute and chronic?
Why do I make a difference? Treatment can be slightly different. Acute sinusitis usually has no surgical role. You gotta remember, sinusitis is a medical disease. Okay? one of the biggest things is, I personally think, I think the Academy also agreed, we are maybe overdoing sinus surgery. Patient who, when do we, this is something I'm going to get into, okay? Sinus disease, sinusitis, it's a medical disease, period. Surgery is there to help sinus problem. It's not a cure for sinusitis. So this is one of the key points I want to address a little bit later. Okay, so how we treat sinusitis? So now everybody understands a little bit, right? Usually, even with viral or bacterial sinusitis, nowadays the recommendation is antibiotics for acute sinusitis. So the key is to make the right diagnosis. Okay, that's the number one thing. You got to make sure you do have sinusitis. When you have first sinusitis, what we do usually first line treatment is giving antibiotics. Now, which antibiotics are usually given? Usually we're giving amoxicillin, it's a penicillin derivative of sinusitis. I see a lot of doctors also give Z-Packs for sinusitis. Doesn't work because overprescription of Z-Pack, to me, it's like candy. Anytime I have a cold, doc, I have a cold. Can I get a Z-Pack? Well, that's one of the most common lines I come into my office, wants a Z-Pack. Okay, I do a lot. For a healthy adult, you'll get a Z-Pack. Nowadays you even get augmented, which is a very strong antibiotic. American Academy of Laryngology has, I'll show you. Actually, I put it here. This is their current recommendation. I'm sorry, the line is a little bit too long. That website, AAO, you can find this article on there. Okay? So their statement first, you got to really make sure it's a differential diagnosis. Make sure it's actually a sinusitis. You should differentiate between bacteria and virus. How do you differentiate that? Usually virus sinusitis lasts about 7 days. It should get better on its own. Okay? Bacteria, a little bit longer. Now, what it is, do you need to take imaging? No. When you first get acute sinusitis, do not get a CT. A lot of radiation. A CT scan has it's about 20 times of a plain chest x-ray. Okay, so there's a lot of radiation involved. What do you do for sinusitis? Answer your question, okay, for people who has acute sinusitis. What do you do? Congestion, everything. Usually it's optional, but I think most of the physicians is also recommending analgesics, Motrin, Tylenol for the pressure, for the pain. We also recommend topical nasal steroids. Although, that's optional. Some people do, even though nasal topical steroids is a great drug, I give to a lot of my patients. Usually Flonase, Nasonex, these are all steroid topical. Is steroid bad? I get a lot of patients ask me, this is topical. It doesn't really get absorbed into the system, so the systemic effect is very minimal. The only side effect is usually it can dry out your nose. People who are prone to nosebleed, gotta be careful. If you're on Coumadin or a lot of blood thinner, just be careful. If you have a nosebleed, stop using it, okay? Some people don't like the smell, and sometimes can cause a little bit of headaches. So those are the only major 3 side effects from nasal steroids. So, it's a pretty good drug, and it can really help with the nasal symptom. However, there's another caveat. If you just give away one spray, it doesn't work like that. You got to build up the medication. You usually take about 3 to 4 days before you get better. About 90% of the patients I see, they've been placed on nasal steroids by their doctors for either allergies, rhinitis, or sinusitis for multiple reasons. Okay, every one of them, most of them, actually I would say everyone, 90% of people come in and says, it doesn't work. I'll tell you why. Because they used it once, doesn't work. They throw it away. Also, another thing American Academy found out is that patients don't use it correctly. Now, so which way is right? I'm going to show you 2 methods how to use nasal spray. Let's say this is nasal spray. One way I do this, this. Which way is the right? 1, 2, or 3?
2.
2. Nobody said 1. Oh, that's really good. It's actually 3. American Academy actually recommend tilt your head down, put the nasal spray inside your nose, point it towards the side a little bit, and gentle sniff. Don't sniff too hard. Okay, so 3 is correct. You can do 1, it's not too, you can do 2, it's not terrible. Don't do this. When you do this, everything goes back your throat. You're not going to like it, and it doesn't work as well. So, do it this way, okay? If everybody about nasal steroids.
What about the neti pot?
Sure, neti pot, it's a great drug. I mean, it's a great, well, drug, what do you call it? It's a great method. It works, it certainly works. It works great for sinus, even for rhinitis, we recommend it too. The only downside for the neti pot is if you, well, it is a saline, even though it's isotonic, meaning it's the same osmolarity between the inside your cell and your blood and the saline. It's good, but when you use it too much, sometimes it can also dry our nose, cause nosebleed sometimes. Not often, but I usually highly recommend it for a patient who has rhinitis, allergy, and sinusitis. Yeah.
On a daily basis.
You certainly use it on a daily basis, but remember, use it before you use the Flonase, otherwise you wash away all the medication. Okay, well, people, you'll be surprised, they'll spray it and then go wash their nose.
Flushes out the nasal cavity, right?
Huh?
So it flushes out the nasal cavity.
Yeah, exactly. When you use it, one of the other things, the neti pot has two types. One is that little teapot, you drain it. Some people find it a little hard to use. Or you use the squirt bottle. I usually tell people use the squirt bottle. Don't use it too hard, because use it too hard goes into the eustachian, into your ear. People do get that. So gentle. What I tell, go in front of the sink. Even if you want to do it in front of in the shower, when it's steamed out, your open nose is already open, like this. Hold your breath. Give it a squirt on both sides. It's the best way to do it. Yes, go ahead.
What about the pills like loratadine?
For sinusitis, yes, it can certainly help, because a big component of it is also allergies. Allergies can cause nasal, if you have allergies, definitely I would say antihistamine can help. Okay, so loratadine, it's basic Claritin, right? Zyrtec, all these medications, Benadryl, they're very good for patients who really have allergic rhinitis. It helps a lot. For patients who has sinus disease, for people who has chronic sinusitis, if you have symptoms over 12 weeks, it's certainly something to try. Okay? Now, there's another thing I want to talk about sinusitis. Also, there are a school of thought. Chronic sinusitis, like asthma. Patient who has asthma has pretty much very similar thing with sinusitis. It's basically inflammation, the lining of the cavity. What is asthma? It's inflammation of the bronchus, right? The treatment is pretty much the same. You give steroids, cool down inflammation. But what is causing the inflammation? It could be viral. It could be a hypersensitivity, meaning allergy symptoms. So, again, what do you do for asthma? You treat it medically. You don't do surgery. That's why usually sinusitis it's really a medical disease. Okay? Other couple of statement. Choices of antibiotics, usually, again, first line treatment is amoxicillin. Also, what about for people who can't take penicillin allergy? Usually what we recommend is Levaquin or moxifloxacin, but be careful on that. There's a new warning label on Levaquin is tendon rupture, so be careful on that. I tend to not to use Levaquin anymore. And the third line usually is what we recommend is clindamycin. Was another new, with the third generation cephalosporin. Better ask your doctor, they will usually prescribe the right thing. But usually for uncomplicated patient, does everyone really need antibiotics? Not really. If you're a healthy 30-year-old who has no medical history, come to me for, say, doc, I have about 4 or 5 days of runny nose, pressure, nasal obstruction. What should I do? I'm like, wait it out. Huh? Yeah.
Get more sleep.
Get more sleep, exactly. Take some Tylenol, use some nasal steroids. Let your immune system do the work, okay? There's a big problem nowadays with bacteria resistance. That's one of the biggest things we are actually concerned about, okay? I'm not saying that antibiotics are not good for you. It's really tailored on individual. For patients who are over a lot of diabetes, for patients who are over 65, who comes in with sinusitis to me, if I see the pus coming out, I usually do start antibiotics as a first line. Okay, especially they've been having it for a few days or they've been treated already. So I do start with them. And I usually do start, for patients who are elderly, I do start augmented, which is a little bit more, a stronger antibiotics, which has less resistance than amoxicillin. Amoxicillin is still a great drug, but it's starting getting resistance because we do overprescribe at some point. Okay? Yes, go ahead.
You mentioned before that babies in our
Oh, not necessarily in our country. I'm just saying babies get ear infection more than adults. It's the way the eustachian tubes are really built up, and we don't really fully develop the muscle that opens up the eustachian tube until we are about 9 or 10 years old.
No, it's not for the children, so they don't change what we said.
Yeah, so what opens the eustachian tube in the back of the nose is actually your palate muscle. Every time you swallow, how you know how your ear you'll pop? Because the little palate muscle opens up. It's attached right next to the eustachian tube. You know who gets a lot of ear infections are kids who has cleft palate. Also kids who has Down syndrome, because these muscles are not very well developed, so they tend to develop middle ear disease when they're kids. So any Down syndrome, any cleft lip, automatic it's a set of tubes. Yes?
Do ear infections, are they related to removal of the tonsils?
Ear infection related to tonsil.
Adenoid.
Adenoid. Okay, so this is a different school thought. So kids, usually when kids develop adenoid, what is adenoid? Adenoid is a pad in the back of the nose. It's flanked by the 2 eustachian tubes, okay? And kids, it's very big. Most kids have very hypertrophic adenoids. It's big, okay? It's a big lymphoid system. But as we age, when you get to 17, 18, it gets much, much smaller. But however, kids who develop a lot of ear infection, first line usually ear infection for middle ear disease, we treat it with antibiotics. Okay, we don't do any drops because the infection is behind the drum, so we can't get to that. So that's why we do recommend antibiotics. For patient who has kids who have recurrent antibiotics, the AL, the pediatric AL, what we recommend is tubes. Tubes are we basically puncture the eardrum, put little tiny tubes there, so the pus can drain out, and also makes, because their eustachian tube is not open, the pressure is always negative. That's why they get, remember I showed you the picture before? That's why they get the ear infection. By putting the tube there, you create an opening to the outside, so it gets ventilation. So they decrease their chances of infection. Now, if they still get, after the tube comes out, they still keep on getting infection, that's the next step. So what we do is we take down the adenoid. What happens, the adenoid gets so boggy, it pushes on the eustachian tube. So evidence has shown that patients who take out the adenoids actually gets better. Tonsil has nothing to do with it.
Okay, because my son had a ton of ear infections.
Yes.
And then when he was around 7 years old,
Yes.
he had a tonsillectomy.
Tonsil, if you have ear infection, you should get an adenoidectomy, not a tonsillectomy.
Oh, okay. Well, I don't
Right.
remember.
Tonsils here.
Yeah.
Tonsils we remove for kids. We do a lot of tonsil adenoids, yes, for kids. Adenoids more for ear infection, whereas tonsils are usually for throat infections. For kids who get throat infection. Also, another important thing, pediatric ENT, is sleep apnea. Kids get a lot of sleep apnea. If their tonsil is too big, they stop sleep, they can't sleep well at night, they urinate at night, they don't do it with their school. So sometimes you might want to take your kids to an ENT, make sure they don't have sleep apnea. Go ahead.
I want to ask you about, if you're like in a place with a lot of noise,
Yes.
sometimes it's hard to hear that stuff. Is that like,
When you're in a place with a lot of noise, you feel like you can't hear very well. You can't make out words.
yeah, like you hear like someone talking next to you.
Talking.
I don't mean where it's loud, where like like an
Right.
airplane. I mean like be in Times Square, for
Yeah.
instance.
Well, that's what the part I was talking about. You could have high frequency hearing loss. You might, yes, when it's too noisy at a certain level, if the background's too much, you can't hear something. But if it's just, check this, next time have a TV on, have someone talk to you, see if you can hear. If you don't hear very well, get a hearing
I
test.
took the hearing test because I always tell my wife to blast up the TV because I can't hear it.
Yeah,
I took the hearing test. The guy said it was fine.
that's fine.
I took the hearing test.
Sometimes it could be, I'm not sure, I have to see your hearing test first, okay?
Yeah.
It's fine, when they say fine,
No, he said it was just someone my age. It was, I was a little hearing loss.
See, that's why. So when they say someone your age, you probably have that down sloping hearing loss. Even though they say fine, where your speech, where you're talking about from 250 hertz to 2,500 hertz, you're okay. But the really high frequency, you're losing hearing. That's the area where you are discerning the words. You can't make out clearly. So that's why. Yes?
With children's, we were just talking about the ear infections.
Yes.
If you have a block, a city block,
Mm-hmm.
and every family except one, the kids are all running to the doctor constantly with ear infections, is there any heredity factor, environmental factor? Anything they can pin down? Say, like that?
I mean, that's kind of hard. I'm not sure if that I have been listening to everybody on the block has infection, but we know that kids does get it. I mean, yes, if they have allergy, their nose is always running. You got to remember, kids not only eustachian tube is small, their nasal cavity is a lot smaller. So they're more likely to get rhinitis. They actually do have, kids have the nose is very boggy. Sometimes, you know, we could give like Flonase and these things to kids too, if their symptoms don't improve.
Because if it doesn't, one place just runs out the nose and.
Yes, it's true. It's true. Again, you know, kids is more of an anatomic issue for ear infections. Some kids do better if they don't have a very boggy adenoid. They're more likely not to get too much ear infections. So it's also development how their eustachian tubes are. You have a question? Yes.
Did you ever see a movie called The King's Speech?
Yes, I have.
You think that was true? He could
This-
talk without stuttering as long as he was listening to a record. And then when he came home and listened to his own speech, he found out he wasn't stuttering at all.
That may more have to. I'm not a speech pathologist. That's speech is a pretty complicated. It's pretty complicated, so I'm not 100% sure. I can't answer that question very well. And it could be possibly true. You know, the stuttering is something that we deal with a lot. So that's more of a speech pathology. That's why we have speech pathology too. I mean, other stuff I can talk to you about speech, about voice issues, which I can talk about because those are anatomical problem causing it. But if it's stuttering, it's more a neurological issue that I'm just not very expert in.
And I've heard that asthma is also related to psychology, that people who have dependent personalities tend to have asthma. You ever hear that one?
Hey,
No, I have not heard that one. Sorry. Yes.
hope you can hear me. What about laryngitis when it comes? Yeah.
Laryngitis? Sure, I can talk about laryngitis. So laryngitis has multiple. No problem. You know, I'm here all night. I'm happy to talk about it. I'm actually like that too. No problem. Okay. Oh, okay. Oh, sorry. Just let's finish this really quick. Okay. So sinusitis, right? I just want to go through some of the statement. I already talked about what we need to for antibiotics. Now, what happened? You failed the first time. If you didn't get improved after a course, how long do you need antibiotics for? Usually, anywhere recommend 5 to 10 days. Okay. The courses really doesn't matter as much because shorter course has less problems, less side effect on antibiotics. But mostly, I usually tell my patient about 7 days. That's tailored to each individual patient. The other statement is if you really fail, the second treatment is make sure you have the correct diagnosis. Make sure there's no other red herring. Make sure it's not a dental pain causing. Make sure it's not a fungus growing inside the sinus. This is something else. People who have allergies, sometimes fungus can get into your sinus and causing problems for you. Okay? And that can be, it's an allergic reaction to the fungus. And usually people get only one side of sinus problem. Most bacterial, viral sinusitis are both sides. If you get only one side of problem, a lot of time you got to be careful because unilateral sinusitis is not very common. It can happen, but a lot of time it can be a couple things. One is pay attention to your tooth, to your teeth. Sometimes if you have a tooth infection that goes up, it sits right underneath your sinus. I've seen a lot of patients who had dental work done and they develop sinusitis after they have dental work. Okay. Second, you make sure you have allergic fungal sinusitis. How do you diagnose allergic fungal sinusitis? Patient one-sided, you get the same symptom, but it's only one-sided, not both-sided. And what happens is you look at inside, you have pus coming out, and you treat them, they don't get better, and you finally, when they don't get better, you get a CT scan, you can see the fungus on the CAT scan. Okay? So those things you gotta be careful with. Just make sure you got the correct diagnosis. Now, most people by now should get better. If after all that, it is a bacterial sinusitis, after you confirm your diagnosis, you can try a second round of antibiotics. Amoxicillin doesn't work, you can try Augmentin. If you initially start Augmentin doesn't work, you can try the Levaquin the second line, or you can even switch to the third line. Usually it should help. Some people even add a little bit of steroids, oral steroids. Now the evidence on oral steroids is controversial, but usually steroids has a lot of side effects, so you gotta be careful for people who have diabetes. So a short course, not a high dose, is okay in people who have really bad sinusitis or chronic sinusitis. Okay, but again, tailored to each individual patient. Every patient's a little different. Yes?
What about a spray with just salt water?
Spray,
As far as getting it to drain and such?
just the over-the-counter little spray?
Or spray?
Yeah.
Saline.
No,
Saline, the saline, right.
Yeah, yeah,
When I do the saline, I
Usually
usually,
water.
that's what we
Mix
just
yourself.
said.
yeah,
You have to do it
oh,
boil
mix
it.
yourself,
We
okay.
used to boil it. and-
Sure, the problem is you don't know how much to mix. You don't know if you make it hypertonic or isotonic or, you know, really too high, hypertonic. If you have too much salt in there, you rinse your nose, what happens? You draw all the water out of your nose, you get too dry.
Right.
When you have a little bit and you get too wet, your nose gets more swollen. So the one that they prepare in the store, the neti pots, they really made it for you. It has a little baking soda in it. So I don't recommend you do it yourself. And be careful. Use distilled water or boil the water yourself. There is one case in I think North Carolina. Someone actually,
Water or something.
yep, well water. Patient died.
It's neti pot.
Yeah, neti pot. They died because it had some weird
Right into the
parasite right into the brain.
Bacteria.
So be careful also on sinusitis. Even though it's like a cold, if we have sinusitis, it doesn't get better, it can cause major complications. So what are these complications? I want you to at least know about these. What is around the sinus? Your eye, right? Your head and your brain. So what happens? When you have a sinusitis, stuffy nose, not getting better, you get erythema, meaning get redness around the eye. You can start having eye pain really bad, or you get really bad headache, not just the pressure here. It gets worse and worse. Make sure you do treat it because these can turn into medical emergencies and that can be pretty dangerous. So make sure you guys get checked. I mean, if you've seen these symptoms, tell the patient to go. Okay. Yes. Oh, I thought you were asking a question. Yep.
I have found over the years, I do get these every winter,
Huh?
by sheer accident, that there are certain pressure points that will drain the sinuses.
Pressure point around the sinuses?
Pressure
Do you
point
get, okay,
here,
right here?
and also here.
Pressure, just pain? Do you get runny nose? Do you get,
Yeah, the whole.
so you do get this runny nose, you do get the
Yeah,
stuff.
but it
Well,
runs clear, but it's.
Is it doing winter change, temperature change?
Yeah, now.
Right now. So you could have, remember before I said you have the vasomotor rhinitis?
Right.
You could have vasomotor rhinitis, which leads to edema inside the lining. It blocks the passages, and you get more pressure buildup. It certainly can.
I find really that there are certain pressure points that
Just-
will actually drain it out. I mean, I'll be choking it out, but it'll come out.
You mean draining?
Yeah.
You mean actually running
drains
down?
it with- Right on either side of the nose,
Uh-huh.
and on either side of the nose. and the
It's
bottom.
probably
Just
pressure,
by
because your nerve comes out right here. The
Yeah.
too big nerve comes out right here. So most people feel the pressure right here. Okay.
Press on it.
Now, before I go, just one last thing. When do you need surgery? What is sinus surgery? When do we use that? Sinus surgery is for patients who really don't get any better. And that's when we do sinus surgery. Now, what type of sinus surgery? You probably heard a lot about balloons and endoscopic sinus surgery, right? One of the things, what balloon surgery really do is, basically what we do is minimally invasive, we can do in the office, we dilate these balloons. So on this picture, what they do is they insert a little catheter into the nose and inflate it. So you see right there, you put the catheter in there and it is made a small balloon. Basically make up the opening. And you can do the same way and they can irrigate it out. It's an easy procedure. However, I think we all may be overdoing it because most people gotta make sure you have the right diagnosis. Okay? A lot of people who has rhinitis doesn't really have sinusitis and they get these balloon surgery, which is, I think, is unnecessary. It's only when you fail medical therapy multiple times, when it's not better, then you can consider surgery. Just remember one thing, I think the message is sinusitis is a medical disease, not a surgical disease. So don't jump ship onto surgery right away. Okay, so that's my main point about sinusitis. It's a treatable, it's like asthma, it's a medical disease. Usually make sure the main point is make sure you get the correct diagnosis. It's not allergy. Make sure to rule out everything and make sure to what to look for. What a warning sign. You know, people can have fever, but fever doesn't necessarily mean you have a virus or bacteria. You can have either way you can have fever. But when you have these symptoms, definitely do go to a doctor and just check it out. Okay? So, questions. Let's answer questions. No questions. Yes?
I would like you to make a statement.
Yes.
You've already warned everybody about the overuse of CTs of the sinuses and the dangers in them. Please make a comment about the overuse of nasal endoscopy.
Nasal endoscopies, sure. So what that is, that's a picture of nasal endoscopy. Now, patient comes to me for sinusitis. Do I scope everybody? No. If a healthy gentleman comes into my office, I don't do nasal endoscopy. What we do is called anterior rhinoscopy, which can just give me a good, the most important for your doctor to know is history. At med school, we all learn the most important thing, history. You can make 90% of your diagnosis on history alone. The next 10% is physical exam, okay? All other CT imaging, all the technology. Nothing beats history. So when my patient come out, I ask them about history. If you have these symptoms, then I go on to do my exam. I use my history to lean onto my exam, okay? So if you're uncomplicated, you're not having a lot of symptoms, just a couple of days, I don't need to put a scope in your nose. If you have an allergy symptom, your symptom sounds like allergy. What do? I look into your nose. I do an anterior rhinoscopy. I actually have it. Looking at the nose on that picture. Put a finger up here, I put a speculum, look at it. These are the two inferior turbinae. Now that picture is a nasal endoscopy. I don't scope everybody on that. That's only when I hear people who doesn't get better, you're up in antibiotics, I suspect something else. That's when I do it. Same thing with CT scan. Do you need a CT scan for every sinusitis? No, I do not scan people. Only if I suspect people who has bad sinusitis, I suspect something else. If I suspect fungal disease, I suspect you have a lot of polyps or some type of tumor. That's when I get the CAT scan. Or if you're not getting better, I'm planning for surgery, then I do the CT scan. Okay, so CT scan has got a lot of radiation, so don't do it. And Dr. Mel is saying that right now, endoscopy. Endoscopy is uncomfortable when you put that camera in. I had it myself. I had many medical students train on me. Oh man, caused me a nosebleed. So not good. You can certainly cause nosebleed. When we train it, we do it on each other. So depending on how your partner is. If your partner is rough, not good. Can certainly cause a lot of nosebleeds. And is it really going to change it a lot of? I'm telling you, when I do rhinoscopy, I do on people who actually really have disease. But when we're resident, we do rhinoscopy on everybody. Most of the people do not have pus coming out. You're not going to see it. And even patients who come with me with sinusitis, they've been treated multiple times, I scope them. Sometimes I still don't see discharge. I don't see pus. It's all normal exam, and it's not going to change my diagnosis. Okay? Again, history is the most important thing. That's why go to your doctor, tell them everything. Okay? Yes? Everybody almost have a little bit of deviated septum, okay? However, some people have more than other. If you can't breathe out of one nose from deviated septum, sometimes more than 75%, 90%, that's when you could use surgery. Now, what deviated septum does, the septum can come across here, and what it does, it pushes up this thing called the middle turbinate. All the sinuses here drains into this area. So we have a very deviated septum. It can certainly, anatomical wise, block the nasal drainage. Does that answer your question?
And so you'd be more prone to sinusitis?
Technically, because even though you have deviated septum, it can, in a severe case. I'll tell you this, I've never seen anybody who has a very deviated septum, and that's the reason causing them to have sinusitis. No. But it can cause you to have breathing problems. Why do you have to come? Because they can't breathe. Because it can deviate so much, you lift up the nose, and all you see is the septum. And that's the patient I do surgery. And not everyone needs it. I'm telling you, everyone has a little bit of deviated septum. I have a little bit of deviated septum. It's when we do these types of surgery for a patient, I don't jump ship. You gotta try it. Insurance company actually will tell you, you have to try medical treatment first for 6 months. What is medical treatment? Flonase, sinus rinse. This is what the medical treatment for 6 months. See if you can improve. A lot of people just have allergy. Why does deviated septum matter? Because when you have deviated septum, if you have that boggy turbinate on the side, you have both when it's really big, when it's swelled up, and that's when your nose gets completely blocked up. So if you use Flonase, usually you can't improve your symptom.
Laryngitis.
Okay, laryngitis. Okay, sorry. No problem. Laryngitis. I'll talk about the most common laryngitis I've seen, okay? That is the reflux laryngitis. So what is reflux laryngitis? I get a patient come to me, about 9 out of 10 has this. I got a globus sensation. Doc, I have phlegm stuck here. I feel like I have a ball here. Sometimes when I eat stuff, it doesn't go down, but it does go down, I have that sensation. And I have to clear my throat like this. This is called chronic laryngitis, okay? Acute laryngitis is actually a bacteria or viral infection. You get very hoarse, your voice can't change, because the larynx, what is it, the larynx? It's your vocal cords and stuff above it, okay? For adults, you get laryngitis, it's not a big deal. For kids, you get laryngitis sometimes because the airway is narrow, so it can be a little bit dangerous. For adults, because your airway is fully developed, it's pretty big, so it's not a big deal. And just like a cold, it can be viral or bacteria. So first line, if you're healthy adults, you usually get better with just over-the-counter cold medication, wait it out. But after 6-7 days, you might want to, it's not getting better, you want to treat it with antibiotics. Okay, that's for acute laryngitis. Now chronic laryngitis, there's multiple reasons. Sometimes post-nasal drip, if you have a sinusitis or if you have you can certainly drip down and irritate your throat. Allergy can certainly irritate your throat. Also when people have reflux. A lot of people have reflux, okay? Two types of reflux. Some people, I get people like, but I don't have the burning sensation, the heartburn. Some people get the heartburn. Other half of people don't get. They get the silent reflux. Whenever they wake up in the morning, everybody wake up in the morning, get the bitterness taste in your mouth. That's from bile. It's from the acid bile reflux. Okay? But most of the time, the globus sensation, people feel like there's a ball here that's stuck here. That's because where the esophageal opening is edematous. So when we look at down with the scope, to look at down the larynx for people who has a little bit dysphagia or people who has this type of sensation, we see it in the back, there's a little bit swelling. Even the vocal cords, under the vocal cords, it gets a little bit swelling. And also for this type of people, don't take antibiotics. No antibiotics in the world can cure you, because this is not due to an infection. It's due to a chronic inflammation, okay? A PPI certainly can help, reflux medication, but that's not going to cure you, and that's not going to take all the symptoms away. The symptoms is because the swelling, not because too much. Yes, you have a lot of acid. Everybody produces acid. You can't. There's no amount of anti-acid medication can stop all the acid in the stomach. You need the acid to digest your food, right? But for people, why do you develop an acid reflux? Some people, it's just because they're the sphincter, which is opening in the stomach, might be pushed up a little bit, so they naturally tend to have reflux, okay? And it's constantly irritating coming out, and it can irritate the throat a lot. So what I do with patients with common reflux, talk to them, change their life habits. Don't eat too much. Don't eat too, if you have these symptoms, you feel like a globus sensation, you feel like there's a throat there, drink plenty of water, cut down the soda, nothing too sour, nothing too spicy. Don't eat too much food. When do you produce the acid? When you eat food. That's when your stomach starts producing acid. And what? Most important thing, don't lie down after you eat. Give it about 3 hours. Sit up. Okay, walk around's okay. If you're really tired, you get the itis, sit on the couch at 45-degree angle, close your eyes. Okay? So this is what I tell my patient to do. We usually also can give them a little bit of a trial of acid pill. It certainly can help, but it takes a long time for this type of chronic laryngitis to get better.
This is cold laryngitis.
Cold laryngitis?
From the cold.
From the cold?
Yeah.
Usually from the cold type of laryngitis.
Rhinitis, whatever.
Yeah, rhinitis is a cold laryngitis. So this falls more into the category of well, it could be an infection directly at the larynx. So usually those should get better within 1 week to 2 weeks. If not better, I think acute antibiotics should be better. But usually these are the symptoms very different. It's not like indolent type of discomfort. It's more of a pain. Okay? Some people who have laryngitis, also their voice changes.
Yeah.
You see what their voice, it's hoarse. You like talk like this a little bit, okay? But if you have this and it not get better, it's better to take a look, because it's very difficult to diagnose, actually, to look. Anytime you have a voice change like this, there's something wrong with your vocal cords. That means either it's swelling, it could be a little nodule, it could be a little polyp. You should take a look at it, especially if you're a smoker. You have voice change not getting better, take a look.
It's like a sore throat cold.
Yeah, sore throat cold, usually, again, these are bacteria. It's like a cold. It can certainly spread down along the tonsil.
Yeah.
Around the back of the mouth, your tonsils, the base of tonsil, this whole area is all lymphoid patches. It's your immune system. There's where it works, okay? This is called the waterline ring. And when bacteria and virus, your mouth is full of bacteria. It's one of the dirtiest places. But, your body can respond with immune system. It's when you're tired, the immune system doesn't work well, the bacteria or virus will multiply, okay? Again, if you're a healthy adult, usually you should fight it within 6 to 7 days. But if you don't get better, I think that's time to seek help, make sure it's nothing major. Second of all, treat it with antibiotics. You might need to get treated with antibiotics, see if it gets better, okay? Drink plenty of water, okay? More questions? Okay, go ahead.
For hearing loss.
Yes.
Other than having gone through ENT,
Mm-hmm.
what about a neurologist?
Us.
Is
They
there such a
don't
thing-
deal with strictly, they don't deal much with,
Is there such a thing as a neurological ENT?
there's a neuro-otologist.
Oh, okay.
They deal with hearing a lot. They're basically ENT trained, but they do 2 more years of fellowship, but they do a lot of skull-based surgery, but they do deal with ear a lot. They actually only work with ear. They don't do any other ENT stuff, only do ears. Those are the people where you go to for, like, if you have a tumor on your hearing nerve, it's a little bit more complicated, that you need to compress. Or if you something like, you have a Meniere's syndrome, where you have maybe you get vertigo, it's basically the hearing nerve and your balance. Don't forget, inside ear, I didn't tell you, the cochlear is right next to your balance system. So a patient who has vertigo, that's another big topic. They have a lot of symptoms with hearing loss, ringing in the ear, and vertigo, spinning sensation. All this stuff together can
They're
cause it.
called a
Neuro-otologist. Not many around. They're only really, they do ear, but they're surgeons, they're specialty surgeons. So if you have hearing loss, they're hard to get to. And you don't know who's who. So usually, just for standard hearing loss, I would say go to just a regular ENT. Or even go to your audiologist. This place is great. Get a screening test. See what it is. Okay? But one of the things is, just make sure someone look at your ear. Make sure it's not just wax. Because audiologists sometimes, they'll look at it and say, oh, no, it's wax. When if she does a hearing test without taking out your wax, your test is going to be false. Okay? So sometimes you might want to just make sure. Yes?
affiliated with a hospital?
Am I affiliated with the hospital? Yeah, I work in New York Presbyterian Queens. I'm a private physician, but I do their operate. I don't do their clinics, but I go there do all their surgeries. My office, I have 3. I mostly work in the Asian community because one of the things is I came here as an immigrant. I was a little kid, 11 years old, so I still speak a lot of Chinese. I'm trying to get back to the community, so mostly I work with Chinese people, but I see everybody. So if you come to see, you're welcome. I don't have my card here, unfortunately, but I'll leave a note here with everything. If you need to, certainly come on in. I'll be happy to. My partner is also very good. Our office in Flushing, Dr. Jerry Ho, he's very respectable, and he's a great surgeon and an ear doctor. So if I'm not there, because I only spend half a day in Flushing, the other time I'm in Chinatown and Brooklyn. So I'm in all 3 communities going back and forth. So. Yes, go ahead.
What about post-nasal drip that comes at this time of year?
Post-nasal drip, that's the one. So post-nasal drip, many things can cause post-nasal drip, okay? It's, again, not a disease, it's a symptom. Sinusitis most likely can have post-nasal drip because gravity-wise also goes more likely to the back than the front. Second, people who have vasomotor rhinitis can also have post-nasal drip. When you lie down, nothing's going to come out. So you got to be careful, see what is exactly causing the post-nasal drip. Most people who has post-nasal drip has vasomotor rhinitis. They're just running. Depend on what your symptom. If you have clogged nose, if you're just runny nose, it really depends. Okay, yes?
Did you show a picture of the middle ear?
Yes, of course.
How was that taken?
How is that what?
How did you get that shot?
The video or the picture?
The picture of the middle
We
ear.
have so we have a little camera. We have an endoscope. The same thing you do for the nose, it's a shorter version. We can put it in your, take a picture of your ear.
How do you get to the middle ear?
How do I get to the middle ear? Surgery-wise, you mean?
No, if you wanted to take a picture.
If I want,